Good afternoon. So now we are really testing your commitment to hear a strategy and global targets at 4:30 in the afternoon after coffee break. So I will try to go through this as forcefully as possible. There's a few slides that you will have seen before, so I will skip over those quickly, and I think we will be able to catch up on some time. But as Garrett has said, we do feel this is an important part of the meeting. Many of you may have heard about the ongoing development of a draft of a strategy for hepatitis, the first global strategy for hepatitis, and also the first global targets. And again, many previous speakers today have already alluded to the elimination targets, and I now have the pleasure to present them to you as work in progress. So I will, first of all, quickly talk about why do we actually need a global strategy and what is a global strategy. I will then talk about the targets that will obviously have to be ambitious, and I think we all are driven by ambition, and sometimes we are limited by some aspects of feasibility, of course. I will then present just a snapshot of the global strategy itself and speak to the strategic directions within that, and then also brief you a little bit on the process, what has happened and where we are going from here onwards. So why do we actually need a global hepatitis strategy? I think previous speakers have very well illustrated already that hepatitis, and we all know it, constitutes a major global public health threat. We also have seen in a presentation earlier this afternoon, progress is very uneven and it's inequitable. We have major access gap to some of the key interventions, treatment being one, testing being another one, some of the prevention interventions, harm reduction, etc., that are still there. Stigma, we have talked about, social exclusion, and other barriers to those services for a lot of people, but also for certain population groups, key populations. But on the good side, on the positive side, we do have new opportunities. We have prevention interventions, new medicines, new technologies. So we need to take them to good use. And the atmosphere in which I think this meeting also takes place, but I think it goes beyond this meeting room, is there is a new era of ambition out there, a new area of attention, and it's driven by a lot of advocacy activities that are currently taking place as the world looks towards the global health agenda in 2030, and as new targets in this regard and new goals in this regard are being articulated, and where we obviously as people coming from the hepatitis community need to find a good place for hepatitis to be well articulated. Very quickly, you have seen this. So from a numbers perspective, there is really an epidemiologic imperative to take action. You've heard about the high and increasing burden of disease, where hepatitis is now number 7 on the top 10 leading causes of mortality. We have 400 million people out there that are chronically infected with hepatitis B and C. These are huge numbers, and sooner or later, all of them will need treatment. We also know there's geographic differences with the highest prevalence in Asia and in Africa. If we compare with other disease areas, and we don't want to pitch them too much against each other, but I think it is fair to really see and recognize that viral hepatitis, the mortality linked to viral hepatitis, is actually now greater than it is in HIV/AIDS and tuberculosis and malaria. And what we also see, of course, is that there is a trend over time where we see an increase, while in HIV, and I'm very happy to say this, report this, also working in HIV, where we see declines, and the same is true in malaria. So in these other disease areas, what has happened? And I think many of you are aware that we have seen in the area of HIV, we have seen a terrible time 20, 25 years ago, where people were dying in millions and where there was very limited and unequal access to the new life-saving drugs. But over the last, again, 15 to 20 years, this has changed. And now we are looking in HIV to end the epidemic by 2030, basically to eliminate it. The same is true in TB, the same is true in malaria, and obviously all those disease programs are taking advantage of looking towards 2030 in the context of the Sustainable Development Goals. So where are we then with hepatitis? And I hope you really agree with me, and I strongly believe that we should be proud that there is now the moment where hepatitis is getting on the global agenda. Largely, this has been driven by advances in treatment and obviously with the latest generations of hepatitis C treatment that have triggered a lot of attention to that in the media that has translated into simply greater awareness, but also greater awareness of some of the access limitations that exist. The good thing is we have several champion countries that are showing the way. We heard some of them speak, several more here in the room. But most everybody who spoke about it says, well, you know, we want to do it, but it's going to be expensive. And where would the money come from? And what we see currently is there's still continued limited global funding as well as national funding, domestic funding. But in the presentations we heard, there are major opportunities, and there's a set of key interventions that exists that needs to be taken forward. And clearly, we will talk about the investment case on Friday in the funding session. But I can already say now, we do have evidence, and we do have the data that show that action will be cheaper than inaction. Or to turn it around, not to act will be very expensive. So prevention and testing and treating will obviously save costs in the medium and long term, of course. So let me talk a little bit about the next part. So what does this mean in terms of targets? We've already heard about the World Health Assembly resolution. We have not yet much talked earlier today about the Sustainable Development Goals, where hepatitis is formulated as one of the sub-goals that speaks to ending epidemics of HIV, TB, malaria, and it says combat hepatitis and other diseases. Some of us would have liked to be this word, not combat, but eliminate as well, but there has been a lot of consultation over the last year, and this is what's going to be put forward to the UN General Assembly in about 10 days in New York for a final endorsement, and possibly more discussion. And there's the growing movement around hepatitis, as I mentioned, and I specifically want to say that the voice of the patients and the demands being articulated by civil society is stronger than before. And it's very clear that patients, rightly so, demand access to key interventions and treatment being one of those. We have talked about the increasing number of countries with national plans, and also we have seen that some of the global partners, but very few for this moment, are expanding their scope on where they put their action and also where they put their money. We will have UNITAID. We have UNITAID with us. It's one of those partners that are carefully moving into this direction. There's the Clinton Foundation that is considering that, and we have MSF with us, Médecins Sans Frontières, who is the real brothers and sisters in arms in moving the agenda there. So what do we mean by elimination? And what's the vision there? It's really a world where viral hepatitis transmission is basically stopped. And ideally, everyone has access to safe, affordable, and effective treatment and care. And what do we mean by elimination? And I'm just saying this because some of us use elimination and eradication interchangeably, but in fact, we shouldn't. Elimination as a public health issue of concerns, where we remove sustained transmission and basically bring it down to a very low level, and where we remove hepatitis as a leading cause of mortality. It doesn't mean that there's nobody with hepatitis anymore, and it doesn't mean that nobody at all is dying of hepatitis anymore, but it should be brought down to a very low level so that it is no longer a public health issue of concern. While obviously in eradication, smallpox eradication, the disease did no longer exist, the virus was eradicated, so it's different, obviously. We know it's technically feasible, and we've seen some modeling data in earlier presentations by scaling up key interventions, and these are 6 key interventions. Previous speakers also talked about them. It's hepatitis B vaccination, including the birth dose, safe injection practices and hospital practices, more broadly speaking, that includes safe blood, harm reduction for injecting drug users, safe sex, including condom promotion for certain populations, hepatitis B treatment, and also hepatitis C treatment and obviously cure. So these first global targets, what type of targets are they? First of all, we want to look at impact. What can be achieved in terms of reduction of incidence and mortality? And is this good enough so that we can say with confidence, this is no longer a public health concern? And secondly, coverage targets of these interventions. And there, again, obviously, we have to balance feasibility with ambitions. And in terms of the time that we are looking is, again, 2030, but we want to have a milestone, a very fixed milestone for 2020, which is also in line with the lifespan of the strategy that we are developing. So let me walk you through the coverage targets. On the left-hand side, you see, again, the interventions that we've just listed. On the right-hand side, you see basically the baseline where we are in 2015. And with the exception of HPV vaccination, which does not include the birth dose up here, we see relatively low baselines. There's less than 1% coverage of treatment for B and C. Obviously, very low harm reduction. We've heard it in the previous presentation. Safe injection practices are relatively low. We just introduced a global strategy, and the birth dose globally at 38%. So now, the difficult moment that we have to go through is to say, and to agree as a community, so to speak, on what do we think can be achieved in 2030 in terms of moving from those relatively low levels of coverage to much higher levels of coverage. And those are usually defined at about 80% or 90% in line with what we would call universal access. So what we discussed, and we put a whole group of global thinkers together. We had a think tank meeting in Geneva to really discuss what could be some of these defendable coverage targets. And these are the numbers we came up with for 2030. Remember, we have 15 years to go. We need to be ambitious. And we also have some milestones, which are somewhat less ambitious, because obviously the time is much shorter for 2020. But I want to highlight certainly one milestone that is, I believe, very, very important, and that is the 8 million treatment target for 2020 in 5 years, which would be 5 million for hepatitis B and 3 million for hepatitis C. So this is certainly one of the more important slides of this presentation, and we can come back to it. If we do these things, if we achieve those levels of coverage, what would be the impact? And we would achieve, according to the modeling work we've been doing with Imperial College, we would achieve a 90% reduction in new cases of chronic hepatitis B and C infection. Obviously with a milestone again in 2020, which is somewhat less impressive. And that would mean that from where we currently are, and we define it as a range, from the 6 to 10 million infections this year, it should be brought down to less than 1 million. So this is the 90% reduction. In terms of death, we looked through the various, we built various assumptions, and we would have a 65% reduction in 2030, with a somewhat less impressive reduction by 2020. But we would achieve a reduction from 1.4 million deaths now to under 500,000 deaths by 2030. And this has to do with the fact that obviously access is not to the large numbers is not happening so quickly, that we need to scale up, that some people may be at a stage of disease where they still die, regardless of they may not be reached by therapy early enough. If we do this, we have also done a calculation, how many deaths would be averted over this 15-year period. We would avert 7 to 8 million deaths, or in other words, we would save 8 million lives, which is obviously a very impressive number. So these are the targets. Now, the big question is, how can we make it, well, feasible? We probably can strengthen the health systems to get it out there, but how can we make it affordable? And clearly, with the costs that we are currently paying for treatment in many places, this will not be possible. So we will have to bring down the costs further, and in some places dramatically more than where we are, specifically for medicines, specifically for some testing, diagnostics, etc. We will also have to become more efficient in using the resources, because currently in many places, people are treated, but they're treated with the wrong things that also cost money. So we really have to get rid of ineffective treatment and ineffective care, which is quite prevalent, specifically in some of the middle and also in some of the high-income countries. When we do the costing for the hepatitis strategy, we cannot assume that the hepatitis would pay everything. We really have to look at cost sharing with other strategies, such as HIV strategies that also fund harm reduction, immunization strategies, blood safety, etc. And as I already said, co-infection with HIV and so the border service delivery strategies that countries are putting forward. And we'll have to think about innovations. We will not be able to do the same thing for the next 15 years in the same way. We will have to simplify many interventions. First and foremost, we will have to simplify testing. We've talked about it just now. We will have to simplify treatment. Currently, in most places of the world, even in low and middle income countries, treatment is done by highly trained hepatologists in highly specialized centers. If this is what we continue, we will not reach the numbers we need to reach. We need to get treatment out of these specialized centers, and we need to get it into non-specialist care. And obviously, we will have to find a hepatitis cure. I know some investments are being made, research and development is ongoing. We need it sooner rather than later. And there's possibly other ideas of innovations that we need to think about in terms of service delivery, etc. I'm not presenting, before I move on, I'm not presenting the full costing figures of the strategy. On Friday, Stefan Victor, my colleague, in the context of the funding discussions that we have, the funding panel, we will present to you our current, again, it's work in progress, on the costing, global figures that this strategy will cost between now and 2030, and also how the cost development would be based on reductions in incidence. So let me spend just 2 minutes on the strategy itself. This global hepatitis strategy, the first one, as I said, of its nature, is for 6 years. It will start in 2016 and will go until 2021. This is how most global strategies are being developed for a 5 or 6 year period. It will have the elimination targets, obviously, that I'm talking about, and the 2020 milestones. And it will have 5 strategic directions. Basically, all WHO strategies, they are developed together with member states, with countries. They have 2 elements. The first element is what countries should be doing and what countries are committing to do. And the second element is what WHO, as the secretariat to these countries, to these member states, is committed to do in support to their action. So, in each of those 5 strategic directions, those 2 elements will be captured. Just to walk you quickly what those 5 elements are. Strategic direction 1, we talked a lot about the need for better information, for better data, for strategic information. So this is the first strategic direction, because it will inform the program on who to treat, where to focus on, geographically, population-wise, etc. The second strategic direction is what are the interventions that countries need to take forward. I think this is a fairly straightforward part. We've had a lot of discussion about it already today. It's the what, obviously prevention, testing, treatment, care, etc. The third one, often overlooked, but I would say equally important, is delivering the services for quality and for impact. And that is the how. And the how is very important, given that in a relatively short time we want to reach many people with some of those services, some of these interventions. We'll have to think about how do we maintain the quality and how can we make our approaches equitable, particularly in a scenario where some subpopulations are often, we've talked about it today, sidelined, discriminated, excluded. Injecting drug users being one of the cases that is obviously very relevant for hepatitis C. We'll also have to think of policy changes, possibly legal changes that need to be thought about to address these issues. The fourth one, is about financing. What is it going to cost and how are countries financing? There will be different ways, different models, different approaches. We're going to discuss it on Friday in the panel. And the fifth one is, how can we accelerate? And what is the innovation? We've already talked about things that we have to do differently if we really want to get to those endpoints that we are committing ourselves to. Just one slide on the timeline, just to give you the notion that this is not something we have just started. We started more than a year ago after the executive board in January. We had a lot of consultations already with experts. We have put together a civil society reference group. We had an online consultation. We had regional consultations, one hosted by Brazil, one hosted by South Africa, and we had consultations in basically all regions. We now have the regional committees coming up, where member states, again, will see an advanced draft. We are using every opportunity, and we are right here at the World Hepatitis Summit to get some more feedback as well. And we hope to take this strategy to our executive board in January and to have countries, all the WHO member states, basically review it and hopefully endorse it in May next year and adopt it as the strategy. An adoption of a strategy basically means that countries are committing to implement the strategy and also be held accountable for reporting on progress of the implementation of the strategy. So that's an incredibly powerful tool. And we had a side event also, just showing you three photos here. We had a side event at our World Health Assembly this year where we had a packed room of people, some of them very highly placed in their constituencies, in their countries, discussing a draft of the strategy. Egypt was again one of the examples, countries that highlighted its approach. Obviously we had the community, we had Raquel Peck, who's here with us in the meeting from the Alliance, who spoke very eloquently of the patient perspective. And we had my boss, our Director General, Dr. Margaret Chan, who publicly committed that next year, which is next May, the World Health Assembly will address strategies for viral hepatitis, HIV, and sexually transmitted infections. These are three strategies that WHO is currently developing. As I said, for viral hepatitis, it's the first time. My last slide, so what will it take? Not only to finalize the strategy and endorse the strategy, but really also to move full steam forward towards implementing the strategy with the vision of elimination. I think it will take a lot of energy of all of us and many other people out there. It certainly will take commitments. We certainly have people in the room who have expressed their commitment, but many more will have to do the same. And it will take resources. It's not going to come for free, but it's going to pay off. And it's either we pay now or we pay much more later. We will need to rethink some of the approaches, and I've already alluded to it. We really have to move from a very highly patient, individualized way of care and treatment to a public health approach where we think of any way of simplification, where we have to start thinking about integrating the services into the broader health service agenda, not create another super vertical program. We'll have to obviously think about affordability and equitable access. The other thing is also very clear that nobody can do it by him or herself alone. Governments will have to take the lead. Civil society will have to be a strong voice and will have to be heard in every step of the process. And it will also require other partnerships, including with the private sector. And clearly, and to link this back to one of the themes of this event as well, it will require very concrete, comprehensive, but tailored action in countries. And the best way of doing this is obviously for countries to sit together, to bring the various players around the table and to develop a national plan. So personally, just as a last thought, I'm very encouraged by this event, by having so many people here. I'm really delighted. I'm also want to tell you that from WHO side, we want to be with you. We see ourselves having an important role. We hope we are living up to your expectations. If we don't in the future, just let us know. But we would also like to have you as a critical voice as we move forward. There's still an opportunity for you to provide input into this strategy, because it's a strategy that will have to belong to all of us. It's not a strategy that belongs to WHO. It will have to be our strategy. The latest draft is on the website. There's also a short summary there. Please do send us your comments, and we will certainly want to incorporate them as much as possible. So thank you very much.
Thank you, Gottfried. We have time now for questions or comments. As I said, I think that was a particularly important part of the day, and clearly the leadership WHO is showing is very welcome and vital. Does anybody have any questions, comments?
En fait, c'est un cri de cœur que je voudrais lancer, parce qu'il existe dans le monde un pays où on ne parle pas des hépatites. Peut-être à cause du passé communiste de la Guinée-Conakry. Pour le moment, on ne fait pas de diagnostic, on ne fait pas de recherche, pas de traitement, pas de plan national de lutte, pas de structure. Seul mon ONG SOS, peut-être Guinée, fait la sensibilisation. J'ai deux remarques concernant les représentants de l'OMS en Afrique ou en Guinée. Pourquoi, généralement, ces représentants sont trop passifs? Ils n'arrivent pas à faire réaliser les objectifs ou à faire comprendre les objectifs de l'OMS à nos autorités. Pourquoi ils n'écoutent pas l'ONG locale qui est là, même des rendez-vous, c'est impossible. Bref, je voudrais solliciter, au nom des 11 millions de Guinéens, un plan Marshall concernant les hépatites en Guinée, comme exactement l'a bénéficié la Gambie. Et je vous remercie.
Well, thanks for this comment. The countries that were presented this morning, the Gambia and Uganda, and I want to be completely frank, there are not too many encouraging examples in Africa yet. It's really a whole region where we have a real lack of data, we have a lack of information. We have really the need for many other countries starting to collect this information and to move forward. And Guinea-Conakry, obviously, I know there's sensibilization is starting, et cetera, but clearly we hope, and there will be a discussion at the regional committee later this fall, again on hepatitis, that we can really trigger a greater response in many other countries. WHO is a large organization itself. We are also working on internal advocacy to make sure that our own staff, those who are managing country offices, really also become as proactive as possible. If that is not the case in the country that you know best, then certainly we can have a discussion in the coffee break and see how we can follow up on that. It does require something like a Marshall Plan, but we need to also make sure that hepatitis is really also seen in the context of the broader health plan. I don't think it would be palatable to just have a completely vertical program again as we had for HIV 25 years ago. I don't think the world would be ready for that. I don't think these additional resources, those billions are just out there. I think we have to be very smart to see how we can really use the broader health discussion at this point to move forward. But thanks for your comment, and definitely would like to talk to you more.
Okay, thank you. Number 3, please.
Thank you. My name is Donna Cryer with the Global Liver Institute. I'm also a liver patient. Thank you to the WHO for providing a strategy around this absolutely urgent issue. I, however, want to make sure that the strategy is internally coherent. The last point is that we ask for more innovation, including potentially additional cures, yet at the very first we're conceding that there aren't enough funds available for patients like us, and that there aren't enough resources. And so I would challenge that as our starting assumption, that there aren't enough resources to be able to do the job that needs to be done. Thank you.
Any response?
I certainly don't want to be understood as saying there aren't enough resources. I think we have to acknowledge what it will cost, and then we have to have a discussion on where we would find the resources. And it will have to be a mix of domestic resources in some instances, and it will certainly require some international solidarity, as I would like to call it, of which for hepatitis we see very little right now, to also help those countries who will not be able to pay it all by themselves. So that's clearly the message that I would like to put forward. And again, on Friday, I think we should have more discussion. We'll present the figures. We will have some financing models that we present. But clearly, there is no way out. We will have to find the money. We cannot say it's too expensive. We cannot afford it. Fully agree.
Okay, thank you. Number 6 up the back in the distance.
Thank you. My name is Khalil El-Wardiki. I'm with a group called Coalition Plus based in Paris. My question to Gottfried is, what lessons can we take from the experience of HIV that you referred to in terms of access to medicines these past 10 years? We hear a lot about the new treatment for hepatitis C. They're extremely expensive. What is WHO's approach to, in particular, the role of generic competition to expanding access to those new medicines in developing countries?
Thanks for the question. Clearly, we have learned a lot from the HIV movement, I would want to call it, and I hope we will be able to pull off a similar movement, actually, for hepatitis. In the area of drug access, and you mentioned generic competition, that wasn't so clear in the beginning. And some of those procurement, the PEPFAR program in the beginning had some difficulties in actually buying generic drugs. But what we have been seeing is generic competition has brought the prices down, and this is very important. What WHO is doing, we clearly we do a few things. First of all, we work with countries to look through various strategies of bringing down the prices. We have also a colleague here, Peter Bayer, who works in the Essential Medicines program, which is the program that very much leads that area. The various approaches from compulsory licensing, et cetera, to broader range of IP-related approaches. We work also with pharma to share with them the direction that we are taking in guidelines, so that also we share the demand forecasting that we are doing, so that pharma also knows can scale up the production capacity that it needs. And we also collect information. We have a database that looks at the prices that different countries pay, that is in different locations, so that countries can actually plan for that. And we do pre-qualification, which I think is a very important element. It has been mentioned in the previous presentation, to guarantee actually the quality of generics. So there's a whole range of things, but clearly it is an area that will require a lot of other players as well to drive down the costs. Unitate, the Medicines Patent Pool, to name just a few.
Okay, thank you. Number 4, please.
My name is Douglas Michaels. I'm the CEO of OraSure Technologies, and I'd like to also echo my congratulations on this important work of developing a strategy to fight viral hepatitis. I also, I guess it's a comment and perhaps a question, as I looked at your intervention targets for 2020 and ultimately 2030, which spoke to the percentage of patients on treatment and other important measures. But there was a lack of any targets related to testing and screening for hepatitis. And in order to achieve those 2030 goals, the scale up in testing will be unprecedented. By simple calculation, we'll likely deploy billions of tests for viral hepatitis between now and that period. And so it may be advisable to set some intervention targets around screening and testing as a formal part of the strategy.
It's a good suggestion, yes, we have to consider that. And agreed, it will require a lot of testing to identify those people who actually will qualify for treatment.
Okay, number one, please.
Saeed Allawala, I'm from Pakistan, the Health Foundation. It's very heartening to listen to the strategy you have drawn up by WHO and intend to eliminate the hepatitis prevalent in the world. This global strategy is very good, but I just wonder that a country where there are about 18 million people infected with hepatitis viral are badly suffering, and I think the government is not probably having that kind of interest as it should. So are you taking them on board with regard to drawing up the strategy which we have just seen? Because I see personally that it is completely missing. And while working on these strategies, sometimes this happens that developing country suffers because of maybe the lack of interest from the side of the government. So I hope you're keeping that in mind, that Pakistan and maybe the countries around like India and Bangladesh also gets their due share in the strategy. Thank you very much.
Any global strategy that WHO puts forward has to be done in consultation with countries and has to be endorsed by countries. You know, if we set ambitious targets, some of the countries may say, well, don't commit us to doing something that we cannot do. So these targets that I've presented, they still have to be approved by the member states, including your own country, Pakistan. And clearly, Pakistan, with having a high burden, will have an important role to play. So just to reassure you, there has been a regional consultation where Pakistan was present. And there will be also a discussion at the next regional committee, at the executive board, and at the World Health Assembly, where all member states will have to endorse this. Again, we hope that this strategy will not then be just a piece of paper that countries put on the shelf, but countries then have to report on progress every other year coming back to the World Health Assembly. So it is a tool really to trigger action beyond the adoption of the strategy. It does not necessarily happen in all places, but at least it's a tool with which we as WHO can follow up with countries.
Okay, thank you. Number three, please.
Lauren Sant, United States. I thank you very much. This is very exciting. However, I really would like you to reconsider combating hepatitis. We need to end hepatitis in the world, and it needs to be right there with AIDS and TB and malaria. We have a cure for hepatitis C. It's not acceptable for us to just say we're going to combat it. We need to eliminate it. We have the tools. Let's do it. Please reconsider your wording. Add hepatitis to the end of and eliminate the combating of. That's very bothersome. We have no political will in our country, in the United States, to take care of this. $30 million at the CDC is no political will. This has got to change, and we look to you guys to help us. And thank you, but please make it end hepatitis.
Okay. I would do that in a minute. I would change the slide right now, if that was possible. Just for you to understand, these Sustainable Development Goals are not written by WHO. There has been a process over the last, I think, between 18 to 24 months that has involved everybody and his brother. And where WHO also had a role in the process, but again, it was an incredibly expensive consultation process that ended up with that. There may still be a possibility that this is opened up in 10 days in New York at the UN General Assembly, and we have actually advocated for that, and so have others. I know the World Hepatitis Alliance has, et cetera, et cetera. But if it's ultimately not WHO, he can immediately change this. That pressure has to come from countries. It has to come from governments, because they are the ones who ultimately have to endorse the final wording. But if it was, I think, WHO, and if it was me, I certainly would like to have the end there. But again, it's many others that have to make that decision.
Okay, thank you. I see 4 people still at the microphone. I think we will take those, and then we'll draw the session to a close. At 5, somebody's just arrived. Move to number 4, please.
My name is Lorena Digiano. I'm from Fundación Grupo Efecto Positivo. It's communities from Argentina. First of all, thank you for such a clear explanation of the declaration. And I would like to go into the aspect of affordability. And in this sense, I think the declaration should make a call for national governments to use TRIPS flexibilities, what we communities call health safeguards, because they are really instrument to protect public health. We have identified several patent applications for medicines like sofosbuvir and daclazazvir in our countries. And even when our government have expressed political will to give universal access for people with hepatitis C, the prices that Gilead is offering for sofosbuvir and Bristol for daclazazvir are impossible to afford for our budgets. So it is key that our governments scale up testing, and the case of the treatment, to work with these exorbitant prices. Because if not, all these ideas in the declaration, all these goals in the declaration won't be possible. So we call WHO to work on that sense. Thank you.
Clearly, WHO works with countries to advise on the whole notion of using TRIPS flexibilities. The person who could talk about this much better than I is our IP expert and the department that actually works on that. Peter, are you in the room? Peter Bayer, please, do you want to step up to the phone and address that issue?
Thank you, Gottfried, for calling on me. My name is Peter Bayer. I work on intellectual property issues in the World Health Organization. And as Gottfried said, we are working on the patent issues as well. We have published landscapes on 7 of the new hepatitis C drugs, where we can see where the patents, what patents are important and where they have been filed, so that we can actually give appropriate advice to our member states in which situation they are, whether they have the possibility to buy from generic sources that are actually upcoming. We are working on the pre-qualification of both manufacturers of active pharmaceutical ingredients as well as finished pharmaceutical products in a number of countries to actually enhance competition and actually competition with quality products. And we, of course, also rely on the voluntary licensing programs that are actually starting. We try to support the Medicines Patent Pool in their work. And we also, when we discuss these issues with countries, we of course also look at the what is often called TRIPS flexibilities to actually assess what are the best ways to make these treatments accessible and affordable for member states.
Thanks,
Thank
Peter.
you. Okay, number 2, please.
Okay, my name is Edson Aguilar. I'm from Peru. I speak Spanish. Mi pregunta es la siguiente. Vengo en representación no solamente de las personas que viven en la zona urbana de nuestro país, para las cuales el acceso a las pruebas diagnósticas y al tratamiento para cualquiera de las hepatitis B o C es bastante caro, a pesar que tenemos una estrategia de hepatitis B, pero también en representación de las comunidades indígenas, aquellas que están más alejadas, aquellas que tienen muchas lenguas, muchos dialectos, y que por el difícil acceso a su geografía muchas veces son las menos consideradas en las estrategias y programas de salud. Esta misma situación ocurre en muchos países de nuestra región, en América Latina y en otros continentes también. Quisiera saber ¿no? Cuánto énfasis se puede poner desde la OMS para que nuestros países puedan considerar incluir, ¿no? Por un tema ético, moral, de justicia, de dignidad de estas personas, que puedan acceder a las pruebas diagnósticas y el tratamiento. Otro punto que quisiera conversar con ustedes también es que nos orienten acerca de, hay países que tienen una población bastante grande y que les permite una mejor negociación o acuerdo, digamos, con la industria farmacéutica para poder bajar los precios de las medicinas. No ocurre eso con otros países más pequeños. Quizás desde la OMS, viendo la experiencia del fondo rotatorio, ¿no? de PAHO, por ejemplo, con inmunizaciones, con vacunas, se pueda llegar a adquirir medicamentos a precios más acordes para nuestros países y que eso facilite el acceso. Muchas gracias.
On the first issue, the access of indigenous populations, which is obviously an issue in many parts of Latin America, as well as in other parts of the world. Yes, of course, you will have, when you translate the global strategy in your national strategy, you will have to look at specifically those population groups that are most vulnerable and that are traditionally excluded and give them high visibility. So full support to that. If we need to make this more explicit in our global strategy, we can certainly do this. It's in many instances, as you say, a group that is excluded from many services and is highly vulnerable also to hepatitis. Of course. On the second part, I think the question has more or less been answered. And the PAHO fund specifically, I think we need to have a separate conversation because it's a very specific conversation for the Latin American region.
Okay, thank you. There's 3 remaining questions, so 3 and then 4 and then back to 3, please.
All right. Hello, my name is Petra Hoffman. I'm from Canada. CEO of Hepatitis C Global Initiatives and also board member with the National Association of Hepatitis Task Forces. I thank you for sitting in the hot seat today. And I believe that on account of everybody here today, what we would like to see is we want to be able to trust you and we need some accountability. And I think that one of the things that bothers me personally the most, I entered the hepatitis C arena in 2008 when I was first diagnosed myself. I have researched the heck out of it ever since. At that time, we were told that there are 500 million people in the world affected with viral hepatitis. There was one press release that my charity used a lot in communication, and that was put out by the World Health Organization in May 1st, 1998, that said that there is a world pandemic surrounding hepatitis C, and it gave those same statistics then. I wonder how those numbers are being lowered all the time, and we're being asked to hold to 400 million people when more and more people are contracting this disease. That press release has also been pulled because I looked for it today and I looked for it a while ago and couldn't find it. I wonder why.
So I'm not certain to what press release you're referring to, but indeed some of the estimates have been refined over the years. You know, we also have a global burden of disease study that is imminent that will be released in the Lancet sometime later this year. And yes, since 1989, obviously the data have improved and we have better estimates. And that are more at the 400 million range than the 500 million range.
Okay, thank you. Number 4, please.
Okay, Indeed Ashtorch from one foundation in Mongolia. So this is kind of a comment to in regards to the Sustainable Development Goals. The president of Mongolia, Mr. Tsakhagin Yeltsin, he actually took up this initiative to make the case, make the language in the Sustainable Development Goals stronger for hepatitis. And he raised the issue officially when he met with Mr. Feldman, who's Undersecretary of Undersecretary for the Political Affairs of the United Nations. And so what we need, and the President is willing to take this forward, and he is even willing to send the letters to other heads of states. But what we need to raise this issue at the United Nations General Assembly meeting in New York in 10 days is maybe from this audience too, kind of a coordinated action, maybe a letter or something, so that we could maybe send a petition to the council, this open working group put together the SDGs, and maybe also another letter to their respective governments. So, and if we have that, we are willing, we would like to take that to the President and then maybe try to put together a kind of cohort of countries to raise this issue and then move the hepatitis from combat hepatitis to end the endemic. So thank you.
Thank you. Any comment?
Maybe that leads to the next discussion. We're discussing the outcome document of this meeting, of this forum, and the resolution that would come out of this forum, the declaration that would come out of this forum, to see how we can best word this to use it for that purpose.
Okay, thank you. And then finally, number 3, please.
Hi, I'm James. I am a former hepatitis patient, cured. I'm Education and Prevention Coordinator for Waverley Care, which is a Hep C charity. What I noticed when you were talking was there was no mention of stigma, and there's not been a lot of mention of stigma today. Will the World Health Organization be doing any sort of work around stigma? Because that will increase the uptake of testing, it will increase the uptake of treatment. There is still so much stigma surrounding viral hepatitis, and it really, that's what needs to be looked at. And I'm just wondering if you will be doing that. Do you need a translator?
Yeah, there's no Scottish button here. So.
I'm here. It's okay. Yeah.
Well.
What I asked was.
Yeah, I got it.
It's okay.
So I just wanted to confirm it. Stigma is very important, and I think I think there was some discussion about stigma earlier today when there was an intervention in the early panel. Certainly, this is going to be very well articulated in the global strategy. I can reassure you. When we talk about equitable access, we will talk about stigma, we'll talk about exclusion, we'll talk about vulnerable groups, and we'll talk about the need for removing any barriers. So that's clearly what I think is one of the areas that will make this strategy different than some other strategies where this is not being thought about, because it's a fact. So that's all I can say now. I can reassure you, but please go on our website, have a look at the draft that is there, and if you have any concrete suggestions, please do let us know. If you feel it needs to be said differently, more strongly, we would certainly want to build on additional inputs.
Okay, thank you. Thank you to Gottfried. Thank you to all the people who raised questions and comments. As I said, a very important topic. We will draw the session to a close now. There'll be a brief changeover.